Hello, welcome to Stanford Care's monthly community health talk series. My name is Natalie Louie. I'm a thoracic surgeon at Stanford, as well as an associate medical director of our cancer center and surgical director of our lung cancer screening clinic. I am pleased to bring you the series of talks co-sponsored by Stanford Care, Stanford Health Library, and the Vincent V.C. Wu Memorial Foundation. Tonight, I am very pleased to welcome Dr. Jeffrey Velotta, who will speak on lung cancer screening, incidence, and outcomes in Asian Americans. Asian American men often have a significant smoking history and may be unaware of lung cancer screening guidelines. Additionally, they may exhibit poor adherence to and initiation of lung cancer screening tests. Furthermore, there's an increasing incidence of lung cancer among non-smoking Asian American women. Dr. Velotta, MD, FACS, will discuss potential outcomes of lung cancer as they relate to the Asian American population. Dr. Velotta is a thoracic surgeon at Kaiser Permanente Northern California and an adjunct clinical assistant professor in the Department of Surgery at the University of California, San Francisco School of Medicine. He received his MD from the George Washington University School of Medicine. He then completed general surgery residency at UCLA, a postdoctoral research fellowship in cardiothoracic surgery at Stanford, and a cardiothoracic surgery fellowship at the Brigham and Women's Hospital at Harvard Medical School. His clinical and research interests focus on outcomes after regionalization for thoracic surgery and lung cancer outcomes in Asian Americans. Welcome, Dr. Jeff Velotta.
Thank you, Dr. Louie, and thank you to Stanford Care for the opportunity to give this talk. I'm really excited, and so I'll just get started. Like Dr. Louie had said, we're going to talk about lung cancer in Asian Americans. I kind of changed up the title a little bit last minute to try to give you kind of an overview for everybody to kind of see what I think you may all need to know, importance, and then we'll show a little bit of data behind that, but we'll try to give a whole big higher level picture. So I have no financial disclosures. And obviously we have to say Happy Lunar New Year for the Year of the Dragon. I was actually going to have I would have loved to have a 49ers slide, but for all you 49ers fans, including myself, we're pretty bummed and still have the Monday blues with that. But we'll now focus on lung cancer in Asian Americans. We won't worry about that. And so the way I wanted to phrase this talk really was lung cancer facts, just things that you need to know. And that's going to be kind of an all comers in the United States. But then also I'm going to try to tailor it towards what I think is important for our Asian American population. And then specifically, we're going to talk about lung cancer screening. And when I discuss lung cancer screening, I want you to remember lung cancer screening is a covered screening test, but there is a certain subset of people that's for, and that does include some type of smoking history. Okay, so we're going to talk a little bit about that. And then we're going to go into some of the disparities that I see with Asians in our population and lung cancer. And then lastly, we're going to finish with what I call a hidden disparity, where we're going to talk about lung cancer in Asian American women who do not smoke. And again, they do not qualify for lung cancer screening. So this is going to be a little bit different because I've seen a lot of the questions ahead of time, and I'm excited to get to those at the end. So my talk will only be about 30 to 40 minutes, but we'll get into that. And then some take-home points of how I think we can change things. So if we're to start off with everything, these are just, which is always nice about giving a talk at the beginning of each year, because the American Cancer Society essentially in January, February of each year gives out their new data. Although the data hasn't really changed too much. Every year they update it. But the bottom line is when we look at the most common cancer, lung cancer is not overall the most common, but it's the number 2 most common cancer, right? So for men, it's always prostate, women, it's always breast, but lung cancer is still both in men and women, the second most common. But the part that you really have to remember is the number 1 cancer killer is lung cancer, both in men and women. So while it's the second most common, what you're going to most likely die from is lung cancer. And so that's why we bring that to the forefront. And when we bring our 5-year survival numbers, right? And what that means is what are the chances that somebody's going to be alive in 5 years? Right now for all stages. So when we look at early stage to late stage, so this is all a conglomeration. This is each person's going to be very different, right? But if you look at that, when the American Cancer Society looks at that in the SEER database, which is basically looking at all cases in the United States, it's 25% 5-year survival for all stages. Now, this is somewhat debated, depending on what studies you look at, but overall, we look at the prognosis when we compare survival with Asians versus Caucasians, Hispanic, Black, and there's differences, but in majority of studies, including a study that I may show you that we could talk about offline that I'm looking at right now, Asians usually have a favorable prognostic factor independent of smoking status. And we'll get into some of the reasons why that is. So with the Asian population. But first, we need to, before we get into it, right, we still need to, I like to show this slide because how do we relate lung cancer as it relates to just everything else in the world? And how do we dispel some of these myths and stigmas with smoking and non-smoking and all that, right? Well, let's just start it off that still to this day, more people die of lung cancer than breast cancer, colon cancer, and prostate combined in the United States. And like I said, the overall 5-year survival for lung is 25%. But when you look at that compared to breast, 91%, prostate cancer, 97%, colon cancer, 64%, you can see we're at a clear disadvantage for lung cancer. Okay. And that lung cancer is not always related to smoking. And even if it is related to smoking, right, that's okay. We know that. We know that's the number one risk factor, but that's okay to talk about. And that doesn't mean you deserve lung cancer or that we shouldn't talk about it. And that if I told you that more than 50% of all lung cancers right now diagnosed in the United States are people who have a very light smoking history, quit years ago, 20, 30, 40 years ago, or who do not smoke at all, would you be surprised at that? And I think that's to tell you that there's more than meets the eye. It's not all about just smoking. There's more things that we need to learn about lung cancer. And hopefully we can relate that today. All right. So yes, the survival is still not the greatest, right? Mortality is still high, but it's mostly because of late diagnosis. And in this slide, again, looking at the SEER database from 2012 to 2018, the bottom line is, look, the majority, if you can see my pointer, the majority of people diagnosed with lung cancer, nearly 50%, all comers, right? All race, ethnicity, male, female, are usually diagnosed late stage at stage 4 disease, where your expected survival is 7% at 5 years. And only a quarter of patients are diagnosed real early stage, where there's more treatment options available, better treatment options, and better survival, right? If you catch it earlier, you're going to have a better survival. We know that. So the question that comes up, right? Well, why are we catching it so late, and how do we catch it earlier? Do we have a test that can help that can prevent you from catching it late? And the answer to that is yes. And what is that, right? So it's lung cancer screening. And so how do we change that? And so, and our own Dr. Louie just gave a great, her group from Stanford just gave a great talk 2 weeks ago in San Antonio about that and about what people think about lung cancer screening in the community health fair here at Stanford. And there's a lot of surprises that we're learning, that what people don't know or what they do or don't know. And so if I were to tell you that lung cancer screening actually stemmed and started in 2013, right? 11 years ago, for 11 years, we've been doing lung cancer screening has been covered by most insurances and been recommended by the United States Preventative Services Task Force. Back in 2013, that was all based off of what we call the National Lung Cancer Screening Trial, the NLST. That was a major landmark trial showing a 20% reduction in lung cancer mortality if you got an annual CT scan, low-dose CT scan, which is lung cancer screening, which we'll go over, versus a chest X-ray. And they follow those patients for 3 years. You caught it earlier and you treat it better and you have a less death, right? So that's when it came out, 2013. It was further updated where our current status is in 2021, where now it's age. So we changed up the ages. We decreased the smoking pack year history because another European trial showed, again, a reduction in mortality or improved survival if you got low-dose CT scan versus not getting anything. Okay, so bottom line is a low-dose CT scan can save lives for lung cancer, and the idea is to catch it earlier. So then when we look, what is the screening guidelines right now in the United States for everybody on this call or anybody out there that's listening to this talk? These are what the United States Preventative Services Task Force guidelines cover, that or recommend. Okay, if you're age 50 to 80, obviously male or female, you have a 20-pack year smoking history, or you currently smoke and you quit within the last 15 years. So we call it, the 50, 80, 20, 15 rule. I always think that's easy, but for people out there, it's probably not as easy. But the bottom line is, yes, you can see there's a little bit of It's not as easy as saying, oh, you get a mammogram at 45, you get a colonoscopy at greater than 50, right? We know that. But if you can just think about your smoking history, if you have smoked or in the past or currently smoke, you may qualify, and you would qualify for a lung cancer screening scan by insurances. It should be essentially a free test. With the lung cancer screening test, you also get smoking cessation guideline. So if you are currently smoking, we do a little, there's a worked in that, whether it's with a counselor, health educator, we tell you about how effective ways to stop smoking. And then with that, what a lot of people don't realize, this is why we just have to get to the bare bones of it, right? Is that there's a shared decision making. So there is some things involved when you get a lung cancer screening scan. Yes, it's a CT scan, which we're going to go over, a low dose CT scan, but you do have to meet with the provider. The good news is in 2021, or at the end of 2021 or early 2022, we changed that where you no longer need me as an MD or a pulmonologist or a primary care doc to go over whether or not you should get the pros and cons of getting a lung cancer CT scan. So hopefully that'll make it easier, that it can be a layperson, that it can be a medical assistant, a community health worker that can help you get through that. And the bottom line is now, as of 2022, every single guideline, every single major medical society fully endorsed getting these lung cancer screening guidelines. The reason why I bring up the AAFP, which is the American Academy of Family Physicians, right? The biggest organization that is your primary care docs out there, they had not endorsed initially your lung cancer screening CT scan that I'm bringing up on the slide. After the Nelson trial and after that trial was published, the data was so overwhelmingly in favor of saving lives for a lung cancer screening CT scan that they now fully endorse it. They were the last ones to come on board, maybe the most important ones, but now every medical society supports that. All right. So for you out there that may not know this, what is the lung cancer screening scan? It's a low dose CT scan. It takes 5 to 10 minutes. They do not do any IV contrast, no oral contrast. You can see that's the machine. You just go in. It doesn't hurt. You're supposed to get it annually, right? So the idea is not just one and done. You're supposed to get follow-up. We know from multiple studies that lung cancer screening, and from the Nelson and the NLSC trial, that lung cancer screening follow-up is really important. 60% of the cancers were not caught on the initial CT scan. They were caught on the subsequent CT scans following. So it's like a lung health check. It's like when you get your history and physical, you get your CT scan every year, right? So you have to get it every year, and that's important. A lot of people don't realize that. Well, you may ask, we're in California, right? And this is a Stanford Care Talk, so let's talk about California, right? Because it's really important to talk about California, because we're not always in the conversation when it comes to this. Look how we're doing with lung cancer screening in California. We are the worst state as of this year. The American Lung Association came out, the recent data, we're 0.7%. So all you out, it doesn't report everybody, but you can get the point, right? We screen the least amount of people that are eligible in the country. Okay. California is the worst state. And if we actually went down from 2022, we were at 1%, and now we're at 0.7%. The national average of people getting screened that are eligible is only 4.5%. You can see we got a lot of work to do, right? The highest state is Massachusetts at 18%. So still tons of work to do compared to breast cancer, colon cancer, 70 to 80% rates of screening. So we have a lot of work to do. And how do we do that in California? And so I'm going to hopefully show you some more data from California and how we can fix that. So a colleague of mine, and Lori Sakota, is lung cancer epidemiologist over at Kaiser Northern California Division of Research. She published this in JAMA Open Network in 2021. And this was looking at all Northern California Kaiser members and looking at lung cancer screening adherence, how they followed up. Remember, we told you that 60% of cancers are picked up on the subsequent CT scans, not necessarily initially. So what's the follow-up? If you got a lung cancer screening CT scan, all comers, it's 40%. Not that great, right? And then you can see here, if you see my pointer here, year 2, year 3 in the red arrows, it drops significantly to less than 5% of patients are actually getting their follow-up CT scans. Okay, so that's a problem. We do know that centralized programs are better, meaning a coordinator, a lay navigator, nurse navigator, somebody that can help you get into the system, get you through all that, does help with follow-up, okay? But this is where I want you to focus on, right? Our Asian American population, and this is in the Bay Area, this may be you on the call or on this talk, our Asian Americans had the worst adherence out of any race, ethnicity, white, black, Hispanic. We had the worst. And looking into that a little further, it was a lot due to cultural and language barriers. But if we're not following up, if our Asian Americans aren't following up with lung cancer screening CT scans, we're not going to get the same benefit that they did, as you can see here in the NLST and the Nelson trial. Their adherence rate, because it was a clinical trial closely followed by clinical nurses, they had more than 90 to 95% of patients following up every year, right? That's how you need to get the benefit. So we know that not only getting the CT scan is important, but doing the follow-up afterwards, okay? And that our Asian Americans, we have something to work on. So, what are some of the risks and harms? And I, honestly, thank you to Dr. Louie and her team and Lauren, and her med student. We found that, right? I think on their study, in this talk that I was, moderating, 70% of patients thought that there was risks to getting a low dose CT scan. So then I came up with this slide and I said, hey, look, this is it right here, right? The radiation exposure is super minimal. It's right here, 1.4 millisieverts. You and I, living in California, just are exposed to 3 to 5 millisieverts right here, just living in California, living actually, anywhere, right? And so the other thing to know is Dr. Sakani, a radiologist in Japan, they studied this. They put people through the low dose CT scanner and they took their blood right afterwards, and they found there was no even DNA damage of blood cells. So we know based on data, DNA, everything, you are not going to damage anything or any radiation exposure because it's such a low dose. So there is no risk. There is no harm of getting a low dose CT scan. So your family members out there, you guys can't give that excuse that, oh, I'm going to get cancer because I'm getting a CT scan. Yes, there are different kinds of CT scans that have higher amounts of radiation, but not the low dose CT scan that you get with lung cancer screening. Okay. So hopefully that'll help. So what about the good? We know so this is Deb Riswaller's group out of Kaiser, Colorado, and Anil Vachani at UPenn. We know that when lung cancer screening, LCS volume increases. So roughly Medicare started covering it 2013, 2014. You can see there was really no lung cancer diagnoses, right? Because we just started. But then when you increase lung cancer screening, the lung cancer diagnosis pick up by 20%. And in fact, the nice thing that what we call a stage migration is that what you really want, the benefits of lung cancer screening besides saving lives, is you want to pick up earlier stage lung cancer. You don't want it where you're stage 4, right? So when you increase lung cancer screening, they showed that you increase the amount of stage 1 lung cancers, average annual percent change of 8%. So you increase stage 1, and then you decrease, that's the -6 there, you decrease by 6% per year the stage 4 diagnosis. So you're having a stage migration. You're catching more people earlier where you can do better treatments, right? Well, let me tell you this. For every good, there may be a bad or a pro and con. And, I am definitely a glass half full person. But look, this study by Alex Potter and Jeff Yang, who was a Stanford fellow here, is now at MGH, doing a lot of great work with lung cancer screening. They looked at this and they presented this and eventually published this in BMJ. Do Asian Americans, does it work for us? Okay. Are we getting diagnosed more with stage 1 because of lung cancer screening? Well, it worked very nicely for Caucasian Americans. They went from being diagnosed with more with stage 4 to now being diagnosed with more stage 1 here in purple. However, it didn't affect our Asian Americans. And there's reasons for that. One of that we're not qualified for lung cancer screening, or we're not even getting lung cancer screening. And so we still are more predominantly diagnosed with stage 4 disease than stage 1, even in the lung cancer screening era. All right, well, let's bring you back to another good, right? That's a little negative, but what about another good that's going on for our Asian Americans? Yes, to put it bluntly, which I'll show some data on, Asian Americans are more diagnosed, smoking or non-smoking, regardless, more with stage 4 lung cancer. Okay, but to this day and age, every year, every month, there are better treatments out, even for later stage disease. So it is not, quote unquote, a death sentence. The survival is not 6 months anymore for stage 4 lung cancer. There are many options available. This is my patient Yoko. This is all HIPAA approved. Yoko is my 70-year-old Japanese female with lung cancer, stage 4 lung cancer, diagnosed 3 years ago, still going on fine. But the key is we ended up doing surgery on her, and nobody would ever even think of surgery with stage 4, even 3-4 years ago, even now, right? But the key is that there's different, because we have personalized medicine now, you need to get multiple different opinions. I am not offended if you come to me as a surgeon and you see another surgeon. That is what you should do. Second opinions are good. 10 opinions probably are too much, right? That's a little bit much. But there are so many novel treatments out there for, especially for Asians, because they tend to have more biomarkers. The field is growing at such a fast rate. You need to have your med-onc involved, your radiation oncologist involved, your pulmonologist involved if they have to stage you, your thoracic surgeon involved. Regardless of what stage you are, I think you should have multiple people involved with your care, depending on kind of a lot of different things that we're going to talk about with biomarker status. But either way, it's good to get multiple opinions. All right. So kind of the call to action, right? I've showed you that lung cancer screening saves lives, but I've also showed you Asians have the worst lung cancer screening follow-up and initiation, which I don't have data here for that, but that's kind of what we're seeing preliminarily. Plus, they're more likely to be diagnosed with stage 4, right? So how do we combat all that? Well, this is what we think is going to help. So these are pictures of our nurse navigators and our lay navigators, real people that were out. This is us at Street Fest. So Zhao Ming and Li Ping, we think to combat this, you need active outreach. We need to attack you all. We need to go out there and find you and get you through the process, because you may not understand things, or we'll have to talk to your kids. So we use what's called a lay navigator system to help you get through the process of shared decision making, of smoking cessation, of getting the CT scan. And we do that. We're trying to do that culturally sensitive, right? It helps when we can speak the language. We have translators as well. But the idea is that we're trying to improve lung cancer screening uptake and adherence by employing navigators, calling you on the phone, helping you through the process. The other way we increase lung cancer screening in our Asian American community is we go to the population that we think is highest risk. I'm going to show you a slide, the next slide. The highest risk right now is Chinese American men in the Bay Area currently with limited English proficiency, meaning English is their second language. They have the highest risk right now of lung cancer, and based on their smoking history. And we also know what regions smoke more than others, or have a smoking history and have more Asian population. And we go after that. So we specifically go after that region versus, right? It doesn't make sense to go after a region where there may be not many Asians, or the Asians don't smoke in that region, right? We should go after the highest risk first. Otherwise, it's just not going to be feasible. So here's some data from Nick Tom, Joan Lowe, and Nancy Gordon that I work with, that I got lucky to collaborate with. We presented this at CHEST as an abstract. And basically, this is what I want you to concentrate on. We looked at, there was about 89,388 Chinese American men in our Kaiser Northern California system as of 2 years ago. But in the highlighted branch right here, all you need to know is that if English was your second preferred language, meaning limited, we call it LEP, limited English proficiency Chinese men, they were 2 to 4 times more likely to either be a current smoker, 25% would be currently smoking, meaning actively smoking a pack a day, and nearly 50% have a smoking history that could even qualify you for lung cancer screening. That is a huge amount. And you may say, this is in China, right? No, these are our members. These are our Kaiser members. So this is in our environment here. And I can tell you that the majority, I don't have the data yet, but the majority of these patients are not being screened. Okay, so we need to do that. All right, let's go to phase 3. What do I mean by Asian American disparities in cancer? Okay, so let's talk about us as Asian Americans. We are the fastest growing US racial group. This is nothing against Latin, Black, or anything like that, or this is better than the others, but this is a fact. We're right now at 24 million. We are the fastest growing group, more than any other racial group. Cancer, I have to stress this enough. Cancer is the leading cause of Asian American men and women in the United States. It's not heart disease like it is in Caucasians, Latin, every other racial ethnic group, men and women. Heart disease is the leading cause of death. It's not to say that heart disease is important, but in Asians, it's cancer that kills us. And Moon Chen, Scarlett Lynn Gomez, a bunch of people, and then Susan Shinagawa, who I don't know yet, who I'd love to meet, but I know she's probably been on your Care Talks before. She's a breast cancer survivor, activist, talked about this in this publication. And I think her quote says it all, right? Our problems, meaning Asian American problems, never make the headlines. So these authors came up with prejudices, racism, cultural language barriers, and what I call, well, not me, but what we call the model minority myth, where a lot of people don't pay attention to Asians and cancer because they think that we all are wealthy and drive Teslas and are all scientists, we're all doctors, right? We know that as Asian Americans on this call or on this talk, we're not. It's a very big, diverse. We're a very big, diverse group. But does the NIH believe that, right? So if you look at the total NIH budgets budget, right? National Institutes of Health for Asian American research, it's only 0.17% for Asian Americans. And out of all the clinical trials that are done, 2% are Asian Americans. So how can we relate to that? How can we further advance the field if there's none of our patients or none of our people are in the clinical trials? And let's talk further, right? So I told you already that Asians are the most rapidly growing racial ethnic group. We increased by 38.6%. But where are we increasing, right? You may and I think it's just California, right? Yes, California has the highest concentration of Asian Americans, but look where we're increasing. We're increasing in North Dakota, South Dakota, even in Texas, right? These are the states that are increasing. So this is going to be Asian American research in cancer. It's going to be not just California or New York, or Seattle, right? Or in Washington. It's going to be all over. So we have to pay attention as an ethnic group. And then what about the diversity, right? Just look, if you look at all the disaggregated Asian groups, whether we're a naturalized citizen, not a citizen, US born, there's a huge mix, right? So you can see that we are going to be a huge population. In 2060 surpassed 46 million essentially. And so what does that mean when it comes to the dynamics of everything, right? The model minority myth. Look at this. We have the two extreme groups, South Asian, Indian population, median household income up in the 100,000 versus Burmese population, the lowest at 35,000. We have the biggest dichotomy, the biggest spread of income over median household income for all different Asian ethnicities. So we are not all the same. We have very different subgroups, all sorts of things complicating us. Even more reason why you have to study our group a little bit more, do research. We got to figure out what's going on, right? And I think this really brings it home for a lot of the callers on the call today, right? We are in the Bay Area, right? So let's talk about the Bay Area. Well, did you know that the Bay Area, the largest ethnic group or racial group, more than white, is Asian American? It's 33.1% Asian Americans live in the Bay Area, 32.9% white. And then if I told you that not only are we the highest population in the Bay Area where you and I live, right, in practice, we also have the highest group below the poverty line. This is us in red. That's below the poverty line. So no, we do not all work for Google. We are not all doctors, right? We have a very wide extreme, and we need to know that is disparities. That's lacking. We need to study us, right? So let's put it into perspective. Lung cancer is the leading cause of cancer mortality among Asian Americans. Cancer is the #1 cause of death of Asian Americans. If we disaggregate it like Thompson did, look, Asian, Indian, Chinese, Filipino, lung cancer is the #1 cause. This is in men, mostly in females too, except for Filipino and Asian Indian. But bottom line, it's lung cancer that's killing our men and women, regardless of smoking. Okay. So we need to pay attention to it. And then when we look at the racial distribution with how lung cancer looks from the American Lung Association for Asians, we are 16% less likely to be diagnosed earlier, which I kind of showed you earlier, right, from other studies. We're more likely to be diagnosed at a later stage. The highest incidence of lung cancer in Asian Americans is on the West Coast. This is where we are. We have to start it from grassroots up, right? It's not going to be everybody across the country going to be looking at this. The survival was also shown to be the highest with Asians. So not only are we diagnosed later, we may also have a good survival. So I look at that as a positive, right? Even though we're diagnosed later, there's something different in the biology. And that's debated, right? There's some people show differences in that in different studies, but a lot of the studies, including this, some of the things that I'm looking at preliminarily, we do have there's different biology. Survival may be better, so there may be more things that we can do, and we're going to go into that. So, part 4. So stay with me, guys. Let's talk about part 4. I want to switch gears to what I call the hidden disparity. So now we're going to switch gears to Asian American women who do not smoke. You or we, however you want to put it, the prevalence and incidence is high in this population. These are my patients. These are real people that live here in the Bay Area. And again, this is all compliant, HIPAA approved, but I want to bring it home so you can really see what we're talking about here. And let's talk about some data, right? Now I'm going to start showing you some of the granular data. So Lori Sakota and I and our residents looked at this. We looked at over the last 10 years, all Kaiser Northern California patients with lung cancer. I bet you'd be surprised if I told you that the majority are women. There's more women with lung cancer, all race ethnicity, than men over the last 10 years. And what about if I told you 15.5% of all the patients with lung cancer had never smoked or are non-smokers or do not smoke? And out of those non-smokers, 72% of them are women. And then if I took white versus Black versus Latin versus Asian. It's not to compare, but it's to show that Asians are the number two right behind non-Hispanic white in lung cancer prevalence overall, at least in our Kaiser Northern California population. So highly prevalent, right? This is something that's out there that we have to know. And then if we look at characteristics with these lung cancer patients who do not smoke, they are more likely to be female, told you, right? 72%. But look at this, you're more likely to be diagnosed less than 50. There's a lot of data. There's a lot of new stuff out there on the New York Times. You probably saw that on Good Morning America about younger people getting diagnosed with lung cancer and now even colorectal cancer. Well, we saw that in our data too. You're more likely to be Asian if you do not smoke and you have lung cancer. You're more likely to be diagnosed with stage 4 disease rather than 1, 2, or 3, right? And that's data right now, real time, right? So we need to fix this. This is why we're showing this. So how do we fix this? Well, let's go into further. What about incidence rates? So for you epidemiologists out there, this is kind of the first study that we know of to look at our population to see per year, are we increasing or decreasing in lung cancer stratified by smoking status and race ethnicity? So we looked over the last 10 years, every group, smoking, non-smoking, every other race group, lung cancer is decreasing in incidence, right? And that's what the national data shows. So a lot of people misnomer think that lung cancer is decreasing. Well, it is for a lot of different populations. Well, guess what? Asian women, non-smokers with lung cancer are increasing 2% per year. And this is in our population right now. And that's significant. No other group is increasing except this group. And to further verify that it's not just Kaiser data, we looked at, Scarlett Lynn Gomez's group and Mindy DeRuin looked at this. They looked at Sutter Health and they also looked at Hawaii data. And they too showed increased incidence, and they were able to disaggregate the data, meaning showing Chinese, Filipino, Korean, all were higher incidence of lung cancer versus Black and non-Hispanic white. But this is what's really interesting, right? Japanese American did not have. So you can see different Asian groups are different in terms of even lung cancer incidence. So more things that we have to study. But bottom line, lung cancer incidence is high in the Asian population, regardless of, it's not just at Kaiser, it's other places too. And so to answer some of your questions that you guys already asked was, well, what are the causes of that? Well, we know that biomarkers, meaning mutations in the tumor cells of Asian women who do not smoke, are different. And usually that's caused by what's called EGFR, epidermal growth factor receptor. What we're going to talk about in a second is, well, what causes the EGFR to change? There's a lot of different inciting factors, and that's what we're trying to figure out. But bottom line is, when you look at these multiple studies, non-smokers, so patients that don't smoke, EGFR Asian, you have a 60% chance of having an EGFR mutation, which is what caused, quote unquote, the mutation in your lung cells to turn into cancer. Okay. And how do we treat that? There's different medications we have for that. But even in smoking, even if you have a smoking history, Asians had a 3-fold higher incidence of, or prevalence of, having EGFR receptor mutation. So you can't just say non-smokers, female. It's Asians in general tend to have different types of biomarkers. So the biology is different, and there's different treatments for that. There's different prognoses for that, depending on what treatment you get. And so it's important to test our patients to get these. What did we do? So recently, we're going to present this in a couple of weeks in Santa Monica at ISLAC and the targeted therapies. And we did see that too. In our Asian versus our Asian non-smoking women in Kaiser Northern California, over the last 7 years, yes, we're nearly 3-fold higher. Asian women have EGFR positivity versus non-Hispanic white, Latin, and Black. So we're seeing that too in our population here. And so that brings us to the next question, which is the UCSF Female Asian Never Smoker study that I'm lucky enough to be a part of. So is Stanford here, UC Davis. And essentially, these are our 4 groups are looking at this. We're trying to see what are the causes of, what's causing EGFR, or whether EGFR or not, what are some of the factors inciting why women that don't smoke get lung cancer? And essentially what it is, it's really easy. You can sign up right now. You can be a control, meaning if you're a female from the age of 21 to 90 and have no smoke and have no, do not smoke and do not have lung cancer, you can be one of our controls. And right now you can see where we're at. So what it is, it's a 20 to 30-minute survey. We can send it any language. We can send it online, send it to your kids. We can send it paper, right? The UCSF team's amazing, right? They'll send all that to you. You fill out things. Cooking status. Did you have an exposure to this? Where are you from in Asia? Okay. And then you get a saliva sample. You spit into a cup, and then you can mail back into us. You don't have to come in to see us, right? That tells us your ancestry. And then we already have your tumor specimens, whether you're at Sutter, at Stanford, at Kaiser, wherever. We already have that. So you just sign a consent form. Okay. So that's it, right? And that's how we're going to figure out, right? We're going to figure out what are the causes. Is it multifactorial, which it most likely is, but what are some more significant causes than others? What affects Asian versus South Asian versus Filipino, right? But I can tell you right now, we've been trying to get patients to do this since 2021. And this is another good news, bad news, right? You can see we haven't even gotten to half of our cases of lung cancer, and we've been doing this for 3 years. We need your help. What's the most common reason why our women are saying no? Well, it's not that there's necessarily no, it's called passive refusal. What does that mean? And you all know we have family members out there. Maybe I'm even like that, right? We call you, we leave a message, or you say, I'm too busy, or you never call back, or you never answer your phone because you think we're telemarketers. We need to change that. We're trying to combat different things. So community awareness is going to help, right? Know that we're trying to help, and it's a really easy study, and you get a $75 gift card, right, to Target or something like that. So that brings me to the last kind of section, which is, well, what can we do for this hidden disparity population? I told you that lung cancer screening guidelines, as they're covered by Medicare, Medi-Cal, Medicaid, you have to have a smoking history, right? These women do not have a smoking history. But there are two studies, one that's recently was published in Lancet Respiratory Medicine, a study from Taiwan called the Talent Study, that was literally looking at 12,000. They looked at men and women, non-smokers, from the age of 55 to 75, but they had to have a risk factor. And that either included a family history with somebody with lung cancer, cooking exposure, a history of COPD, a history of passive secondhand smoke, or a history of gosh, I'm going blank, TB and COPD. And so regardless, you had to have one family history. But you can see, look at the lung cancer detection rate. They found lung cancer in 2.1% of the population. And this is a non-smoking population. Look at that compared to the NLST and Nelson trial. I already told you there's a mortality benefit. They only picked up lung cancer in 1% of the population. So clearly we think there's a benefit in this population. And what about Elaine Shum study, an NYU oncologist that looked at 201 random Asian women, non-smokers in the New York area, no family history, no risk factor. She found 3 lung cancers, meaning 1.5% out of the 201 women screened. So that's even higher than the NLST and Nelson trial too. And she's looking to accrue more. So we're working on that. We're working on starting lung cancer screening studies in our Asian population here in the United States. Okay. So what are the take-home points that I think are relevant to this group? Remember, cancer is the #1 cause of death in our population, Asian Americans. It's not to say that heart disease isn't important, right? That's important. That's prevalent. That's #2. But think cancer is important too. Our family members, our friends are getting affected by cancer. How are we going to stop that? Through research, through extra funding, however you want to look at it, through awareness. Lung cancer, out of all the cancers, is the #1 cancer killer in our population in Asian Americans. So how can we save our Asians? How can we save our family members? Get them into lung cancer screening if they qualify. Get them in now. It's covered. There's no excuse. Medi-Cal, Medicare, Medicaid, California's passed all the laws that will cover your $3,000 CT scan. At the most, you pay $20. Okay. So if we tell our family and friends that aren't on this call to get lung cancer screening, we could save their lives. That's how we could prevent stage 4 and get to stage 1, where you can get better treatment. What about our lung cancer in women that don't smoke? Well, we know that there's no lung cancer screening CT scan right now for you right now, correct? Right? So you have to be proactive about your health. The majority of times we often see symptoms. And if you're having a symptom, don't wait 6 months. Don't wait 3 months. Wait a month. Fine. Get your Zyrtec, get your allergy pill. If it's not getting better in a week, come back to your primary care doctor and get an imaging study. We can catch it early enough, but you got to be proactive. You got to be aware that that's a risk if you're in that demographic. Okay. What else can we do? The famous call to action, lung cancer in Asian Americans. Well, we do talks like this, community health, but public awareness, right? We go to Street Fest. This is us at Street Fest. We go to community health seminars with Dr. Louie's team, right? Let your family and friends know about this. Not only lung cancer screening, if you have a smoking history. So specifically in our men, we see a high prevalence in our Asian men. Get them in to get a lung cancer screening. And the FAN study, right? Sign them up right now. You can be a control. You don't even have to have lung cancer. Sign you up so we can figure out why you're getting lung cancer, and then we figure out how to treat you. Lay navigators, I told you, Li Ping and Xiao Ming, my friends, our medical assistants, they are the future to help our Asian American population get through and get into lung cancer screening, to get through and help us get on studies. And so that's what we're doing. We're utilizing research funding for Asian American population in lung cancer screening. And we're also trying to increase biomarker testing in all Asian Americans, right? I told you that EGFR, you may have a better survival, you have a better chance of going on a pill therapy, right? Well, what happens if I told you we're not testing a lot of our Asian Americans because they don't know you can get biomarker testing? Well, we're trying to change that and we're trying to reverse that. Everybody should get biomarker testing. And we're trying to improve that by having a nursing navigator help get that for you rather than you trying to seek that out. All right, and then a little bit about the pearls. This is Lori Sakota's study, and Ann Singh on here. Our own Dr. Louie is going to be giving a talk in a week, right? February 24th. I'll be giving a talk too. These are the centers. I guess this is all going to be recorded, but this is where you can come out. We can do one-on-ones. We'll be out in person. You can see the different languages that it's going to be in, and we want to get out to the community to talk about where do you think about lung cancer screening. What can you learn from us? What can we learn from you? What are the barriers? Why isn't your dad coming in to get lung cancer screening? We want to learn from you. So with that, I thank all of you. It's a team. It takes a village. And so it's my team that's amazing. So thank you to the care team. This is just essentially the fan study. But again, you can go to QR codes. It's all over the websites. I highly urge you to do that. And in memory of my patient, Christy. So I thank you, and I'll stop sharing. Thank you.
Great. Thank you so much, Dr. Velotta. That was very interesting and informative. Why don't we repeat just once more, who is currently eligible for lung cancer screening?
Right. So Dr. Lou is right. Let's talk about again, 50. So if you're 50 to 80, male or female, obviously, 50 to 80, and you either currently smoke or you have a history of smoking, this is the hard part, but you got to remember 20, a pack a day, basically 20 pack years. And again, we can go offline and talking about that. That's one of the barriers, but a history of about smoking 20 pack years or more. And you have to have quit within the last 15 years, unfortunately, still. So if you quit, a long, long time ago, you may not qualify. But regardless, all I'm trying to say and what Dr. Louie and I are trying to get at is you may not know exactly, but have us help you, right? Or have your family member help you. We can help calculate that for you. Right. The first thing is, that's what you have to do to get that screening. You have to kind of think, well, how long have I smoked? And well, you know how old you are, right? And when did you quit? If you can do that, you qualify. You could go to your primary care doctor and send them an email, right? You can send PAMF an email right now and they'll get you in. They would love to get you in. So hopefully that helps.
Thank you. And how important is quitting smoking in this process?
Great question. So it is very important. And in fact, your risk continues to decrease over time, regardless if you have lung cancer. If you have lung cancer and you quit smoking, the longer you quit smoking, the better survival, the longer that you're going to live. And even if you don't get lung cancer, the longer you quit smoking, the further you go out from longer quit smoking, the better your survival is, the better your health is for just everything, not only related to lung cancer, but just your overall health. So it does help. The longer you can go to stay off smoking, the better you'll do. So it is important, whether you have lung cancer or not, diagnosed or even treated in the past, we know that it's much better. Your survival is much better, regardless, the longer you stay away from smoking.
Thank you. So these screening studies are really to look for lung cancer before someone has symptoms. There was one question, what are the symptoms of lung cancer that people can look out for?
Yeah, what's interesting is actually the most common symptom, and that's the hardest part about it. 60% of patients, all patients with lung cancer, whether you're stage 1 to stage 4, it's cough. It's actually cough. But we know the 3 most common causes of cough are not lung cancer, right? It's reflux, it's postnasal drip, or it's some type of asthma, right? And so that's the hard part. It's cough is the most common. So what I advocate for people, whether it's, one, if you like what Dr. Lou is saying, if you qualify for lung cancer screening, who cares? If you don't have a cough, it doesn't matter. We don't want you to have anything, right? You just go in for your lung cancer screening. Now, if you're kind of on that borderline where you don't qualify for, you can't just get a CT scan every year because you don't qualify for the lung cancer screening guidelines. If your cough doesn't go away, don't just always assume it's reflux or asthma, especially if you're in a certain risk factor or demographic that we're talking about. So what I tell people is, yes, you can get your Z-Pak, which is an antibiotic, right? You can say it's the flu, but if it keeps coming back, it doesn't go away, you need to get an imaging test, at the minimum an x-ray, and if ideally a CT scan. And again, most of you are not going to get lung cancer if you have a cough or even weight loss or not feeling well or short of breath. But it's important, if it's a persistent thing going on and you fit some of the things that I was showing you on the research, then it is important to not let that go a year or two without getting checked out by your doctor.
The next question is regarding what research has been done for why Asian women who have never smoked develop lung cancer. Are there environmental reasons or other factors that people are looking at?
Absolutely, and that's what the UCS the female Asian never smoker study is to try to delineate what those factors are. We know it's multifactorial. People know there's an increase of radon, right? Radon is a risk factor for lung cancer. We know that secondhand smoke is a risk factor. We know that COPD or asthma types in your lungs is a risk factor. We know a history of TB, even in Asia, a history of TB is a risk factor. We know those are all slightly higher risk factors, right? And we know, but we don't know to what extent how that all goes. And so a lot of groups are looking at modeling and trying to figure out, well, based on these 5 different things that you may have, you have a higher increased risk. And then the other thing that people are doing that's kind of novel, right? At the NEH, they're looking at blood tests. What if I told you we could do a blood test on you? It's still experimental, but get a blood test from you and then look at your DNA, different parts of your DNA, and tell you what your chances of getting lung cancer is and what kind of lung cancer you're going to get, right? So that's still all experimental, but do know that it's multifactorial and there are multiple things that go into play. But what we're trying to figure out is there one more than other, or is it all equal that are causing, say, 60% of our Asian American women with lung cancer, EGFR mutations, right? What causes that mutation? And it's multifactorial. With regards to even hormones, right? We know that it's more likely that women non-smokers will get lung cancer than men non-smokers. So there's a lot of factors that we need to still look into.
Thank you. So you told us about the current screening guidelines, which is just for heavy smokers. What advice do you have for people who don't meet those guidelines? So never smokers or people with secondhand smoke exposure or other concerns?
Yeah, so great question. So that's essentially that's what I meant on for you all, the take-home points of be your own advocate. You have to be your own advocate, and that's hard for all of us, right? Not all of us are know that how to do that, or language is an issue. So you have your family members, but bottom line is you have to be your own advocate. So because you don't qualify when you're just because of age and you don't have enough smoking history, you if you do have some type of little symptom or something, it's not to say that everybody should freak out and go get CT scans, but just know if it's something nagging you, it could be something, especially if you fit some of the demographics that we're talking about today, that you need to go to your doctor and let them know, right? You just don't want to go unchecked for a couple of years. That's kind of what we're seeing with the reason why stage 4 is more common in Asian non-smokers is not necessarily because the cancer is more aggressive. It's often because if you look back at their chart, you look at the data, they've been coming to their PCP or they knew they had a cough for years and they weren't getting in checked in. So we just think you're diagnosed later because you don't qualify for lung cancer screening. But I would say to Dr. Louie and to the rest of you is that the one risk factor that we know is the highest in our population, because right, we're just talking about Asian Americans right now, for now, is family history. If you have a family history of especially a first degree relative, especially on your mom's side, a maternal side, but even any family history of somebody in your family with lung cancer, that is a significant risk factor. That is the highest risk we think right now. And based on all the modeling and the preliminary data on a lot of studies, that's the highest risk, the highest chance that you'll have of potentially developing lung cancer is a family history. So one of the things are, right, in our community, we know we have a Bay Area, 33% of you all out there, we're Asian. There is going to be some of you right now on this call are family members that do have family members that do have a history of lung cancer. And if that's the case, that is a higher red flag that you are at higher risk. That has been shown based on the talent study, based on other studies. And your risk goes even higher if you have multiple family members. If you have multiple family members with lung cancer, that is something, and again, we can talk offline about that because there's different coverages and things like that, but there are some genetic studies going on and even trials looking at bringing those patients in to get your blood screen and to undergo lung cancer screening.
There were a couple questions about, along the same veins, self-paying for a scan.
Yeah. So at this point right now, luckily, if you live in California, it's not for all states, but for 38 states, including California, Medi-Cal, Medicaid, Affordable Care Act will cover your lung cancer screening CT scan. So even if you don't have insurance, the Medi-Cal or Medicaid, or you have the minimum insurance, you can get that covered. Now, for those that haven't signed up for Affordable Care Act or don't have any of that, say you don't have any insurance, there are certain programs that they have that certain, but it's only select lung cancer screening sites where you can pay out of pocket or have, I guess, depending on what your money situation is, you could pay a fee. But again, if you have some type of Medi-Cal or Medicaid or something, the benefit of being in California is you can have very, very minimal insurance, and your lung cancer screening will be completely covered. Now, that's not in every state, but in California, at least, it should really be covered. So there really shouldn't be, in my opinion, and I'd love to hear what your opinion is, Natalie, that you shouldn't get it covered, that it shouldn't, that money should be an issue.
Right. I think for people who meet the eligibility criteria currently, we can definitely work with you to make sure that cost is not a barrier. I think it's a bigger question if you don't meet the eligibility current criteria, how to decide
Yes.
to self-pay.
Yeah. So to answer that question, maybe I only answered half the question. To answer that question, because you're right, a lot of people in this may not qualify for lung cancer screening based on this demographic, Asian American women specifically. And I don't say that it's just hearsay to say, oh, we have data to show that the percentage of women with Asian American women with lung cancer that have a smoking history, 2%, 2%. Okay. So we know that whereas our men, it's much higher, 80 to 90%. So we're two different demographics. And so I guess what I'm getting at is if you don't qualify for lung cancer screening, the issue is, I don't know, maybe I should talk offline about this because I don't want to like cheat the system or whatever, but there's ways you can do it. One of the things that you can, but this is for the community, right? So one of the things is that if you're having symptoms, you won't get a lung cancer screening CT scan, but your doctor can order an imaging test, meaning a regular CT scan or even a low dose CT scan, and that will be covered because you're coming in with a symptom, a diagnosis of cough. And so it's different. So I'm not saying you should lie, but I'm saying if you have symptoms, that's one way that it would be covered. You don't have to worry about insurance. The other way, what Dr. Liu is getting at is, yes, there are certain organizations and certain CT scans where you can actually pay out of pocket to do that. However, there's differences with that. So again, it's harder to do. It's also, this is where disparities come up even more, right? There's some patients that are going to know the system a little bit more than others in terms of getting those CT scans, or they'll know the clinical trials. Right now, City of Hope has a clinical trial right now enrolling patients that are non-smokers, Asian females. So that is one way to automatically do it, but then you have to undergo the whole clinical trial process, and if you don't want to travel and all that stuff. So there's some different ways that I don't really necessarily, that we can talk more offline, and you can email me if you're really concerned, or I can tell you what I think your risk may be. I mean, I don't have a magic ball, right? But we can help with that.
Thank you. One question asked more about the FAN study and whether it would cover the cost of screening.
Right. So it does not. It is not a screening study. There is, funny enough, the FANS FANSS study, Female Asian Never Smoking Screening Study, enrolling people in New York right now that they get a blood test, an experimental blood sample that they're working with the company with, and you do get the CT scan covered. But that's in New York right now. So right now, our FAN study here, the Female Asian Never Smoker study, is an epidemiologic study. So it's a survey. You're helping in terms of what are some of the causes or risks and factors that may be leading to your lung cancer or not, based on your race, ethnicity, and all the different things, where you're from, cooking oil, whatever, all that stuff. But it doesn't, we don't give you a CT scan with that. So there's two separate studies when you talk about the FAN study.
Mm-hmm. We are actually at Stanford planning to start a study screening never smoking Asian Americans. And so hopefully we'll have more information about that study soon.
Nice. It's great.
All right. There are a couple more questions about more specifics about lung cancer incidence. For example, is there a difference by country of origin, rural versus urban? I'll combine it with another question. What if you are half Asian? What do we know about those demographics and differences?
Right. So that's more reason why you need to enroll for the FAN study, right? Or other studies like that, not just our study, but other studies too, because we're trying to figure that out, right? That's the whole idea. Do Filipinos have a difference than Vietnamese and that somebody that's half Asian versus not, right? We include all of that in the fan study. You don't have to be, you could be half, part, South Asian, right? Indian counts, all that. So, are there different risks? But we do know based on a lot of epidemiologic studies done by a lot of research at either UCSF or Stanford, all the people maybe on this call that have looked at that, and there is slight differences that we see in certain Asian ethnicities in terms of your risk. So a great example was that paper from Hawaii that you saw that, so I'm Japanese American, right? So we have a higher degree of gastric cancer, same thing with Korean Americans, but you're seeing less EGFR and less lung cancer in Japanese versus Chinese have the highest. We see it higher in Chinese, Filipino, Vietnamese, but we don't have enough Burmese yet, or enough South Asian yet to include that, but we're still figuring that out. But we do preliminarily see, some slight differences in what Asian ethnicity, subtype you are, half Asian, all that stuff. That is harder to know, to tease it out, but we are looking at that with our surveys.
Thank you. And then there was one question that I think you might have partially covered, but just to confirm, can you repeat, what are the radiation risks?
Super low. So the radiation risk is 1.5 millisieverts. So what you need to know is that just you and I walking around in Palo Alto or Alamo or Walnut Creek, we're exposed to 3 millisieverts, double that amount, just walking around in the Bay Area. So one low dose CT scan you get once a year is half of that. So you have no really essentially increased risk with a lung cancer screening CT scan. And what's been shown in the literature to be high, so I said, right, 1.5 is the low dose CT scan. 3 is me and you right now. Me and Dr. Louie right now, we're 3, right? Just all of us, right? And then high is greater than 20. So you'd have to get what? I don't know math that well, 15 CT scans, low dose CT scans to say consider that high. A higher risk. So again, your risk is very low with these type of CT scans for lung cancer screening. Different CT scans, as we all know, that's the hard part, right? And that's why you need to talk to your doctor, your family, or whatever. Different CT scans have different dosing levels. And so yes, CT of the chest, there are different kinds that have higher radiation. But for the lung cancer screening that we're talking about, or whenever you hear low dose CT scan, same type of thing, it's very minimal. You're not at increased risk. And I'm glad you brought that up, because as Dr. Louie knows, that is a concern of a lot of Asians in the community. It's what I see when we poll our Asians. It's what Stanford saw too, that they were worried that people out there are worried about the radiation exposure or the risk of, finding something and things like that, I think are lower on this spectrum of importance and not factors.
One person noted a very interesting cultural barrier, that their family member did not want to talk about being diagnosed with cancer. Any comments about that or other cultural barriers that might affect Asian Americans?
It's huge. That's part of even though I didn't show the other data, but that's part of what I think the passive refusal. So for full disclosure, for me, for the fan study, I'm actually the one calling patients about lung cancer and talking about it and getting it on studies. And obviously, Dr. Liu and I both treat lung cancer from a surgical standpoint. So we have, in our area, we have a lot of Asian patients, and there's huge cultural barriers. Many, when I talk to the Asian patients, most of them say they don't want to join it because they don't want anybody to know. They don't want anybody to know that they have lung cancer. Or if I say that, oh, can I show your picture? That's why it was so vivid that you saw some of those pictures I up, because, it's for every Asian woman that I want, or Asian man that I want to show and highlight and say, hey, lung cancer, this is our people. These are people getting it. Most say no and do not want to share that, and do not want to show that, and do not want to tell their family because they're ashamed, they think, or there's a stigma associated with it. And it's even more pervasive in the Asian American community. And I'm still trying to learn that, because I don't speak, some of the higher incidences in Chinese, and I don't speak Mandarin, I don't speak Cantonese. And, and I was born in California. So I'm still learning that as an Asian American, but it is deep. And so one of the ways, Dr. Louie, that I combat that, I don't know what you do, but what I do is I go after the family members, right? Because I may not relate to a 65-year-old or even an 80-year-old that doesn't speak English as a first language. And so I have to use a translator. So I use that, but they never relate to that. But if I can talk to the kids that may have a higher chance of speaking English or whatnot, that's worked well. And that's gotten me past like, hey, this is really what's going on, and this is how can you help your family, because the parents, I mean, even so now, even some of the patients that I operate on, they don't even really want to talk to me, and I'm operating on them. They want their kids to just talk to me, right? Oh, you just talk to my son, and then I just see him the day of surgery and operate it and get him through, right? So there's a big difference between in the Asian American community that we need to get past that barrier. And I'm learning, just like all of you out there that are learning, but I am learning that there's more work to do. As I showed you, we started that study in 2021, and 3 years later, I haven't got half of our patients.
Thank you. I know we're just past time, so I'll do one more question. What do you think are the next steps in terms of policies or public health initiatives that we could use to increase screening?
So, two things. One, if you for lung cancer screening in Asians, the policy change is that it's more of a community policy change. We already know that lung cancer screenings, if you have a smoking history, but we know that our Asians aren't getting there. So why is that? So we think the policy changes, whether it's public awareness, like we're doing right now, you qualify, go in, you're not going to die from it, but you may live a lot longer if you catch it and talk to family members or use a lay navigator. That's what I think for our Asians, what we need to do for policy change. Right, that we have to let people know that our Asians are dying of lung cancer more than any other racial group, and they smoke it. There's a good amount of smoking involved, and they're not all like maybe me or you that don't smoke right now, right? That there is a high prevalence of smoking. So we go after, we tell policyholders to do that. So to improve the uptake of lung cancer screening. And then on the other hand, the issue with what we're seeing, the high incidence and prevalence of Asian women that don't smoke with lung cancer, I think that's the real call to action is what we're going to try to do is screening, right? You're doing that at Stanford. I have a couple grants in to look at that. City of Hope's doing that. New York's doing that. MGH is going to do that. Irvine's going to try to do that, which is to get lung cancer screening in, or some type of modeling or some type of blood test, which is out there, but to get that up to speed where we can do that and screen this high risk population. It's very rampant in Asia. It's very common to get a CT scan, regardless of smoking or not, right? We're just not there yet because our population is not all Asian, right? We're still majority other ethnicities. But I think that's the change, is that we need to think about screening in this high risk population. And I think, as you heard from Dr. Louie and just from me now, that's what we're trying to work on in our United States population, not just in Asia. Because in Asia right now, what people are doing is there are patients that I have will go back to Asia, will go to China, get their CT scan, and then come back to the States and get their treatment or get the follow-up and stuff here, because it's easier to get a CT scan in China or Taiwan right now than it is to get, if you're not a smoker, than it is to get at Kaiser, at Sutter, or one of those systems. So we're seeing that even now, Natalie, and I'm seeing a lot of patients with scans from Asia, and then they come back.
Mm-hmm. Well, thank you so much, Dr. Velotta. I am sorry that we didn't get to all the questions, but appreciate the questions and discussion, and feel free to contact Stanford Care or the Health Library if you have any further questions. Thank you.